shall be the truth, the whole truth, and nothing but the truth.
Hello again, Mr. Swann.
My lady.
Good morning, Mr. Swann.
Morning.
Would you please give your full name?
Robert Samuel Swann.
And it's correct that from the 11th of January 2020 until 27th of October 2022, and then again from the 3rd of February 2024 to the 28th of May 2024, you were the Minister of Health in Northern Ireland.
That's correct.
We set out with the Chief Medical Officer the structures of the healthcare system in Northern Ireland, so I don't propose to go back over all of that ground. Just want to ask you, when Sir Michael McBride gave evidence, he was asked, did the population of Northern Ireland have the healthcare service that they needed at the start of the pandemic? And he said no. He was also asked whether HSC was actually equipped to meet the needs of the Northern Ireland population at the start of 2020, and he replied, no, I don't believe it was. Do you agree with him?
I would fully agree with both those statements, yes.
Why was that?
Well, I think the inquiry has heard in regards to the status that the health service was in prior to the pandemic. We've been through 3 years of not having a sitting or functioning executive. The health service in itself had been through single-year budgets from the year 2016, and a lot of the reforms, the investments and the dedication that our health service and the health service staff and the people who relied on it had not been delivered.
So is it effectively that capacity was limited by the funding restraints that had been put upon it over the previous years?
It would be a fact that it was constrained by not just the funding constraints that have been put on it, but also the lack of political decision-making and political direction that the health service again needed to make, the transformation that it had needed to make best use of the funding that it had, but also the investment of the additional funding that it could receive.
Okay. And again, as I set out with Professor McBride, as the Chair has set out in the Module 1 report, there's only so far the inquiry can go to look at funding. So in terms of answers that you have throughout the course of the day, if funding is a core issue, please do say, but I think the value of repeatedly referring to funding may be relatively limited in terms of what the inquiry can achieve. But in terms of the funding constraints that you found yourself in, whatever the situation that you found as Health Minister, you'd agree that you had to provide the most effective healthcare service that you could with the resources available to you?
That was correct, but what we also found is, my lady, when I took up post in January 2020, our health service workers, the nurses were already on strike. They'd taken industrial action, the first time that health service workers across the UK had actually been forced to take that step in regards to what they felt was necessary, not just in regards to the financial package, but also the asks that they had around safe staffing. And when the New Decade New Approach agreement was agreed between the two governments as to what was going to be part of the restoration package for the new executive coming in, actually additional nursing training places was one of those core agreements, because there was the recognition that the lack of training places across health and social care in Northern Ireland had been cut due to previous budgets as well.
Well, let's look at your assessment of the state of the healthcare in the end of January 2020. How prepared did you think health and social care would be to respond to a pandemic?
When I first took up the post, in regards to that, our biggest challenge again was the industrial action, but also where Northern Ireland was in the disparate situation in regards to the length of our waiting lists, the worst across the United Kingdom. So the challenges that I faced and our health service faced was also that of additional need in regards to staff, but also the challenges of our waiting lists. So as a priority, as a stress on its own, Northern Ireland, I think, was an outlier in regards to being in a worse position than some of the other health services across the United Kingdom.
Okay, well, let's look at it a slightly different way. By the end of January 2020, did you believe that health and social care would have the capacity to respond to a pandemic?
Not at that point, but because I don't think we had the available capacity built within the system to take on the additional strains that a pandemic would actually present. Because I think, referring to that earlier answer in regards, we didn't have the resource nor the capacity to actually challenge the waiting list situation that was the immediate impact in Northern Ireland.
Mr. Swann, I just want to make sure we're focusing on capacity to respond to a pandemic. Yeah. Those are potentially two different things when we're talking about resourcing other areas compared to responding to a pandemic. I mean, you'd first attended COBRA about coronavirus on the 24th of January 2020, is that right?
That's correct.
Around that time, did you ask what plans Health and Social Care had to respond in the event of a pandemic rather than necessarily just the coronavirus pandemic?
I don't recall that specific question, but I am aware that there was the pre-pandemic preparedness plans that we covered in Module 1 in regards to what was necessary, what different management systems could actually be brought in regards to gold, silver, bronze commands within the health and social care system.
Those are more structures as opposed to physically how health and social care would respond, how it would build capacity, how it would surge in the event of additional critical care capacity needs. Do you remember anything along those lines?
I don't remember anything along those lines, but I think that's where, those preparedness of silver and gold commands were there.
Could I ask you to speak slowly? You're like me, you speak very quickly. So we try and encourage each other to speak more slowly.
Apologies, Melanie.
What did you think would be the major factor or factors that would limit health and social care's ability to extend or expand its capacity to respond to the coronavirus pandemic?
The main factors would be that of available staff, but also space and capacity within the healthcare structures that we currently had. Again, I've already stated, that we were challenged with the number of healthcare staff that was available, but also our structures were across the healthcare estate were ageing and needed update and needed investment.
In terms of the staff, you would have been able in late January, early February 2020 to be able potentially to reorganise your staffing capacity to make sure that the staffing was focused in the areas where it would need to be to respond to the pandemic. Is that right?
That would have been something that would have been an operational decision for the trusts, and I think that was part of that planning preparedness, that the only ability that we had to do that was actually step down other services because we didn't have that inbuilt capacity, that spare capacity within health and social care. And again, as I said in a previous answer, that was one of the reasons that our health care service had actually went and took industrial action prior to the executive being restored.
But in terms of, you say that's an operational decision, given your understanding of the capacity, given your knowledge of what you were hearing at COBRA in January and February, did that make you personally focus on ensuring that there was a maximisation of capacity, particularly staffing, within health and social care to respond to the impending pandemic?
It was an issue that was already there in regards to we didn't have enough staff actually to deliver the healthcare service that we wanted to, even pre-pandemic. So as I keep reiterating, that additional leeway, that flexibility wasn't something that we had available to disperse and actually engage without having to displace other functions.
Yes, Mr. Swann, but that's the point. You're walking in, that's the baseline that you're saying there isn't sufficient staff. The question is, did you put a focus on making sure that you were maximising the ability to use the staff that you had available to you?
I think what I'm trying to say is, yes, there were those plans in place in regards to what we needed to do, but the challenge was that there wasn't the flexibility there actually to do what we would have wanted to do.
What direction were you applying to any planning for the pandemic in February 2020?
Sorry, in regards to?
In regards to whether there were plans, what the response was going to look like, whether there was sufficient capacity being built in, whether there were actually plans in place for how the capacity would be used that could be made available within health and social.
It was in regards to the activation of the pre-pandemic preparedness plans that, again, engaged and actually stepped up in gold and silver commands, where that operational delivery was brought in at Silver Command, where we were bringing the trust together, chaired at that stage by the Public Health Agency in regards to what steps would be taken or could be taken.
Yes, but the question is what you were doing. So Silver Command, Gold Command, they were a level below you, that's right?
Yes.
So what were you doing?
So I was meeting with the senior officials within the department. We were meeting on the executive level as well to make sure that there was also a response ready for across the executive as to how we could respond to a pandemic.
But the executive weren't directing how the health and social care should respond. That's a matter for you as the health minister, is that right?
That's correct.
So I just want to look then at the detail of surge planning for the first wave. So it's right, isn't it, that on the 17th of February, the CMO wrote requesting a detailed surge plan. Do you remember what modelling was being relied upon at that point in terms of, firstly, what capacity health and social care would require to meet the first wave, and also what the peak of wave 1 would look like in terms of when it would arrive?
I think that modelling at that point was coming from SAGE in regards to the figures that were coming across.
Do you remember any of the detail about it?
I don't remember off the top of my head in regards to the January figures.
Okay. Well, if I look at the modelling of 9th of March, if we can please have on the screen INQ 000 425 604. So I believe you're familiar with this document.
Yeah.
And so this is modelling that was commissioned from SPI-MO. Is that correct?
Yes.
And this is the first Northern Ireland specific modelling of the potential impact of the pandemic. Is that right?
Seems to be, yeah. That's correct.
Look at the specific figures in a second. But when you saw this modelling, I presume you saw this on the 9th of March or around the 9th of March. Is that right?
I don't recall the exact date I saw this specific document, but I am aware of these figures.
But it probably would have been given to you around the same time it had been received, yeah. Did you feel that these were the numbers that actually health and social care were working towards in terms of what the impact would be upon them in terms of number of cases, deaths, symptomatic cases, or did this present a dramatic change in terms of the numbers that would have to be dealt with?
This seemed at that specific point in regards to the 32,000 peak daily new symptomatic cases was, I suppose, a stark focus in regards to what Northern Ireland was actually going to be facing in regards to those numbers without any intervention actually being taken.
Yes, but the question was more, when you received this modelling, did it present a step change to what you were working towards?
Yeah, I think it was also at that point, Milady, in regards to the 32,000, the daily hospital admissions of 4,000 possibly per day, was really that point that really made this whole thing real, both to me and to my executive colleagues. In regards to that, there had been hypothetical assumptions as to what could happen, what would happen, what was happening elsewhere, but it was in regards to those specific figures. And if I recall correctly, around that time, I think in the receipt of those, we actually made a press statement, the First and Deputy First Minister and myself, in regards to those figures, that what could actually come about in Northern Ireland if behavioural interventions didn't take place in regards to that.
You just said that these figures were the point that really made this whole thing real. This is the 9th of March. You've been watching what had been happening across the world. Did it not feel real well before that point in terms of what was likely to happen in Northern Ireland?
It did feel real as to what was going to happen in Northern Ireland, but I think, my lady, in regards to when you see that level of a population of 1.9 million people in Northern Ireland, where we could be facing 32,000 cases per day, 4,000 hospital admissions, in regards to what our system, what the population was able to compete with. And again, those figures were without, as the paper says, without behavioural intervention. So I think that was the crux, as I say, that made it real for us, made it real for me as an individual in Northern Ireland.
Did that making it real then provide a different impetus to the level of planning or the pace of planning that was going on at that point?
I think it made quite a different inference in regards to how the rest of my executive colleagues reacted as to what was actually coming, as I said, in Module 2C. Up until that point, and part of the challenge that we had was that up until then, the COVID pandemic was going to be treated very much as a health issue rather than a whole society issue. But when you look at those sort of numbers, and we had the intervention, that those sort of numbers were possibly what was going to happen to Northern Ireland without the behavioural interventions, that's what focused a lot of minds.
Okay, well, as you were just talking about Module 2C there, the other minister's responses was dealt with in Module 2C. I'm focused on the response of the healthcare system and the response of you as the health minister. Are you satisfied then that prior to this modelling, prior to this starting to feel real, that there was sufficient pace of planning, sufficient depth of planning to ensure that health and social care could respond to the pandemic?
I don't think that the surge plans in their totality were preparing for the numbers that we were going to see or were potentially going to see without the behavioural interventions, because as it states there, average daily beds available in Northern Ireland were actually less than what was being expected as the COVID peak daily new hospital admissions. during to that modelling, so it would have crippled our system completely, my lady, in regards to that, if we hadn't took those behavioural interventions that we did.
Well, even taking those behavioural interventions, when you look at this modelling, so peak daily hospitalised caseload of 10,000, when the average daily beds available is 3.8 thousand, peak daily invasive ventilation of 1,000, an average, so total level 3 ICU beds, so that's those that can deal with ventilation, was 100. So a tenth of what the peak daily invasive ventilation. Did you think that HSC had any possibility of coping with those modelled numbers, even with the intervention?
No, and I think that's why the surge plans that were put in place at that stage looked, in the beginning of the first wave, looked dramatically, my lady, at actually stepping down a lot of the core issues and the core services that health and social care were delivering, so that we could best prepare for what was in front of us.
Because 4 days... Sorry. So on the 19th of March, the department published what was called the summary plan for mid-March to mid-April. So that's about 10 days after this modelling had been received. And it's 4 days after the first Covid-19 related admission to critical care in Northern Ireland. That's right?
That's correct, yeah.
So there had been 10 days before that plan was published to respond to that modelling. That's right?
That's correct, yeah.
And the purpose of that summary plan was, as it says, to ensure that there's sufficient capacity within the system to meet the expected increase in demand. That was the point of that plan at that time.
Yes, that's correct.
So by the time that summary plan was published, why wasn't there a defined surge plan for critical care?
Well, for critical care specifically, that was something that the critical care network for Northern Ireland had been asked to work on. Our critical care ICU capacity was 88 beds at that point in time from my recollection. So the surge plan in regards to intensive care specifically was something that was built up looking across those networks, how we actually maximised trust. But again, the limiting factor in regards to be able to supply ICU beds, that critical care capacity, was actually the availability of trained workforce who could actually staff and manage critical care beds.
Yes, but that's not an answer to the question about why there wasn't a defined surge plan for critical care alongside the summary plan that was published on the 19th of March.
There wasn't one developed at that stage that I'm aware of, my lady. I do know that the Chief Medical Officer had asked the Health and Social Care Board to prepare a surge plan, and he had some concerns about that, and it had actually been returned before that one that was actually published was delivered to the department.
Yes, and this comes back to the fact that the CMO had requested that on the 17th of February. So it was over a month since the initial request to when the summary plan was then published. And the summary plan didn't include a surge plan. And the question is, why did it not have a surge plan if the point of the summary plan was to make sure that you had sufficient capacity within the system?
I'm unsure, my lady, as to why that surge plan at that point didn't include a specific in regards to critical care. There was a later plan developed in regards to how we managed our critical care beds across Northern Ireland, looking at all trusts coming together, but also how we actually, at a later date, instigated a Nightingale facility within the Belfast Tower block, specifically around critical care beds.
Did you see the summary plan before it was published?
I would assume it did, yes, from recollection.
Did you ask, where's the surge plan?
For critical care beds? No. If it's not in the submission, my lady, at that point I mustn't have.
No, but as the Health Minister, you're there to critically assess
Yeah,
the submissions that you're getting.
that's correct, yes.
Did you look at this and say, actually, how are we going to scale up critical care here? Do we have a plan in place?
If that's not in that submission at that point, I didn't know.
On reflection, do you think that's a question that you should have asked?
In reflection, yes, my lady pointed out that I was newly into the position in regards to that, in regards to there being no health minister previously, in regards to the specific questions of the surge plan that I could have been asking. In reflection on what I know now is very different from what I knew then. But I can get back to the work that was taken under the critical care network in Northern Ireland in regards to how they were able to flex up critical care beds where they looked at later dates.
Just going to push that one stage further. You say that you were new in the role. It's not a matter of how long you were in the role to assess whether there was actually a plan in place for how you were going to scale up critical care.
No,
that doesn't require experience as a health minister, does it?
It's that ability to be able to ask the right questions at the right time, my lady, in regards in hindsight, knowing what I know now compared to what I know then, I would have asked that question, I would have insisted on it.
So do you think then that, whatever the reason, that you weren't providing a sufficient level of direction as the Health Minister that you believe that you probably should have provided?
Yes.
I think you've also mentioned the Nightingale plan. It was also the fact that the Nightingale wasn't included in that summary plan of mid-March. That's correct?
No, that was Nightingale was a later date.
Okay. The surge plan eventually was published on the 16th of April. That's right?
That's correct, yeah.
You'd received modelling on the 1st of April that set out from, sorry, let me start that again. You'd received modelling on the 1st of April from the Northern Ireland Regional Modelling Group, correct?
Correct, yes.
And that modelling set out when it was anticipated that the peak would arrive in Northern Ireland, that's correct?
That's correct, yeah.
And I think it was anticipated it would be between the 6th and the 20th of April. Is that correct?
As far as I recollect, yes.
So, do you know why the surge plan was only being published at the very end of the peak period?
It was in preparation of what was available, and as I said earlier on, my recollection was that the CMO had asked the Health and Social Care Board to develop a surge plan, and he had queries and questions in regards to that it was returned for the second publication and iteration. But it wasn't to say, my lady, just because the plan wasn't there, didn't mean that action wasn't already being taken.
No, but the action wasn't complete. If you're talking about a plan, you need to make sure your plan's complete to know how you're going to respond to the peak of a pandemic. Isn't that right?
That's correct, yes, but there was actions being taken.
Do you know why, again, maybe this is repeating itself, but do you know why it had taken a month from the publication of the summary plan on the 19th of March to the publication of the surge plan on the 16th of April 2020? What was the reason for that length?
I don't know why that delay was from my recollection of this.
Going to move on and look at the actual surge plan from the 16th of April. Can we please have INQ 000 377 154? Thank you very much. So we can see at the top there, overall planning assumption, modelling on the 7th of April, so 9 days before this was published, indicates reasonable worst case scenario of 140 COVID beds needed at peak, in addition to 35 non-COVID. This requires a total of 175. This plan will reach that target at high surge with a margin for delivery of higher volumes. So at the time that this surge plan was published, it was anticipated, based on the modelling, that health and social care would be able to deal with the first wave of the pandemic. That's correct?
That would be the assumption for critical care beds, yeah.
Yes. I want to look on the left-hand side, please, and it's a section called Key Points. And it says triggering points identified for each phase by CCA NNI. That's Critical Care Association Northern Ireland.
That's correct, yeah.
What was the role of the department in terms of when the various levels under this search plan would be escalated through?
From a departmental point of view, it was up to the CCA and I to actually instigate and move between each module, each stage, each step.
Why wasn't the department exercising effectively the final decision? It could be informed by the advice of the CCA and I, but why wasn't that a departmental responsibility?
Because in regards to how the critical care network had actually been setting up, it was agreed, it was their established practice that they would trigger the additional points rather than the department stepping in to make decisions which were operational at that point.
Is there not a loss of this central element of control if it's not being taken by the department, given the department's oversight of all aspects of health and social care in Northern Ireland?
I think in this specific instance, it was the critical care network in Northern Ireland is made up of those senior officials within each trust, working with the representation, as far as I can recall, from Health and Social Care Board, So it is for them to make the operational decision as to what they need. The surge plan itself looks at different hospitals and different trusts, escalating different numbers of beds at different times, so it is how they deploy their staff and their resource. I personally think it was best left in the hands of those professionals to make those decisions at those points.
There wasn't a regional command structure for managing the surge plan prior to January 2021, is that right?
That's correct, yeah. In regards to critical care?
Yes.
Yes.
So when I say the surge plan, we're talking about the critical care services surge plan. There was an assessment done by a military assessment team in December 2020 that suggested that that regional command and control structure should be brought in. Did you think that there was a loss in terms of the way that Northern Ireland responded by the department not having that central control in 2020?
I'm not sure that there was anything lost, my lady, in regards to how we actually responded, and that's we wanted to make sure that that critical care network and how it actually functioned was as robust as possible coming into the second wave, and that's why we actually commissioned that military assessment through a MACA request in regards to making sure that everything that we were doing was right. They recommended that central control and command structure, which was more robust than what CCA and I believe had previously to that.
Okay. So I want to know, did you have any specific knowledge as the pandemic progressed about how far each ICU had surged over the baseline figure? So i.e., compared to what's on the screen, the number of beds above what's set out in the steady state for each hospital?
There was regular updates on our COVID-19 dashboard in regards to how many patients were actually in ICU at any one time, and those reports would have been coming in every time we surged. I would have received an update.
Isn't it a slightly different matter when you're talking about how many beds there are in ICU across the Northern Ireland as a whole, as opposed to how many beds there are available in each individual hospital? Was it that hospital level information that you had, or did you not have that?
I believe I had hospital information, but not on a daily basis in regards to the number of ICU beds that were occupied both by COVID and non-COVID patients that were available actually on a public-facing dashboard as well. When it came down to that level in each hospital, I don't recall if I was receiving that level of data.
But you're satisfied that the department did have that knowledge?
I would be satisfied that they did, and that also that was being managed through CCA and I.
Okay. The Department of Health's data statement sets out at paragraph 6 that between the 20th of March 2020 and the 20th of May 2022, there were 651 dates when, in at least one hospital in Northern Ireland, all ICU level 1, 2 and 3 beds were occupied. Did you know how critical care admissions would be managed when all the critical care beds in any given hospital in Northern Ireland were full?
Well, that was the rationale for the critical care network, that anybody requiring that critical care could then be supported through another hospital. We also, my lady, at one stage, I think through the CNO, had developed a memorandum of understanding with the Republic of Ireland, where if such a situation in Northern Ireland actually arose that we didn't have available ICU bed capacity, that we could use cross-border function as well. And I'm not aware that we actually ever had to trigger that, but it was something that we had prepared.
When would this have been escalated to you? When I say this, when would a decision about escalation of surge states, whether local escalation, regional escalation, whether one hospital is full, is there any time when that would have been information passed to you?
It would have been after the fact. They wouldn't have been coming to me to seek authorisation or clearance to move from one surge level to another.
I want to talk now about your understanding of staffing ratios once these surge plans have been produced, because if we can look at key point 10, please, again on the left-hand side, thank you very much. Staffing levels per patient will reduce as surge levels progress, staffing ratios across units to remain constant. And then on the right-hand side, but I don't think we need to go to this, there's an explanation about how staffing would operate for each of those individual levels. So, for example, if we go down to step 3, high surge, patient to staff ratios diluted further in line with CCA&I plan. Were you told what were the anticipated staffing ratios for critical care for each of those surge levels?
I remember having the conversation with the Chief Nursing Officer, my lady, because I know it was something that distressed her greatly, that the deletion of critical care beds would be less than one critical care trained nurse per patient across each of the sections. So it wasn't something that was taken lightly. Not every occasion when we escalated actually reduced or caused that deletion to occur from my recollection. It was necessary in some instances, but that wasn't to say that those patients weren't being supported. It meant the ratio of critical care nurses weren't to the desired level that either I or the CNO would actually have wished to have happened. And it has gone back to an earlier answer in regards to our ICU beds, that our limiting factor at the beginning of the pandemic was those nurses who were actually trained to deliver that ICU critical care capacity.
Why was it that the Chief Nursing Officer felt the need to raise it with you?
Because it was, I suppose it was a step away from what was normal. And again, the Chief Nursing and I had a working relationship where those sort of concerns that she had, she could come to me and have those conversations. In regards to being one of my professional officers, in regards to that, it was a step that was necessary, but it was a step that she wanted to make sure that I was aware of was actually something that was going to be necessary to deliver the level of care that we didn't envisage that we would ever have to, but was necessary due to stepping through the different levels of surge for critical care.
Well, does that not reflect the fact that you should have had more involvement in understanding what the surge plan was going to look like and how triggers were for moving between the various surges, and also what happened as the pandemic developed?
And I think in regards to an earlier answer, knowing what I do now, yes, in regards to that, but as the pandemic developed and we stepped through these surge plans, that's why when we developed the Nightingale for critical care and the Ulster Tower block, that's why it was specifically targeted towards that critical care capacity.
Okay. One question before we come to the creation of the first Nightingale. This surge plan, did you actually know where the staff would come from to be able to staff up the increased beds across all the various surge levels?
In regards to these on a specific level, that would have been an operational matter for each of the trusts, but it was by taking staff from other parts of the hospital, delivering other parts of care, that we had to step down to make sure these beds were managed and supported.
Given your concern about staffing and capacity of staffing when you first took on the role of Health Minister, when you first saw this surge plan, did you think to ask, do the trusts have plans in place about how you're actually going to make sure you have the staff to meet the numbers that you've set out in this plan?
And that was, where the other surge plans, not specifically in critical care, actually looked about what services, unfortunately, we'd have to step down so we could deliver the staff to meet the demand that we had through COVID on critical care beds.
Yes. But that's the generality. Did you know the specifics about where they were going to come from?
I wouldn't have had that level of knowledge coming from each hospital nor each trust.
Were you told that there would be sufficient staffing to meet those numbers?
By displacing other services, yes.
We'll look now then at the creation of the first Nightingale. The Department of Health statement says that it was informed by the reasonable worst case scenario modelling. That would have been the 1st of April from the regional group. The department initiated a rapid assessment of potential sites on which to locate a Nightingale hospital facility to provide additional critical care. CMO's statement says that the site visits were on the 28th of March. Are you able to remember precisely when planning for the first Nightingale actually commenced?
I don't remember when the planning actually commenced. I remember the options in regards to a number of non-hospital sites that were explored. I actually was part of the site visit to the Econ Centre in regards as to what a facility it could actually be for the first Nightingale. At that stage, and following various assessments both internally but also in regards to engaging military support, again, there was none of those sites were actually seen or deemed feasible in regards to the amount of physical work that would actually be needed. So that's why the decision was taken to actually step up the first Nightingale within the Tower block within the Ulster Hospital.
Can we just look at a briefing paper, please? It's INQ 000 276 382. And if we just go back a page, this is actually the briefing paper that was sent on the 18th of April. So it's not the first facility but this provides an overview of some of the lessons that have been learned as part of the planning process. So I think it's a helpful document. If we can please go to, just to raise the point that you were just discussing, page 4. And then there's, as you say, first wave site visits. There's a couple of visits. And then paragraph 18, of these 3 sites, the icon was considered the most suitable due to location. However, due to the second visit, a decision was taken not to progress the project due to the amount of work that would have been needed to be carried out in a short timescale in order to make the site suitable. That's what you were just saying there about.
That's correct.
And that's the reason why you ended up, that's the reason why the Nightingale ended up in the Belfast City Hospital Tower. And it's fundamentally because the preferred option couldn't be made ready in time.
That's correct, yes.
Is that a reflection, do you think, of the fact that there had been a lack of planning for Nightingale at an earlier stage?
I don't think Nightingales across the United Kingdom, and specifically my lady in regards to the Nightingale facility in Northern Ireland, it was a critical care facility that we were looking at in regards to where we were seeing the most need of beds. The work that would have been done to make oxygen available, to make all the proper medical necessities available for a critical care bed, the Econ Centre would have taken an inordinate amount of work to bring it up to status, because it is actually a large, basically exhibition centre. It's a large warehouse rather than the facilities that would actually become available by the adaptations of the tower block in the city hotel or the city hospital.
Yes. Those are the practical difficulties that were faced, the reason why it didn't end up in that centre. But I'm asking, should there have been planning at an earlier stage which would have allowed you to then use what would have been the preferred site, apart from logistical issues, as the Nightingale? I
think it was the physical work. It wasn't the ability to assess or actually see what site would have been more suitable. It was the time scale that we had to put the actual physical mechanics, the oxygen lines, the oxygen generators onto site. As I say, the Econ is a large centre that's used for conferences and an agricultural show, more so than being a medical facility. So the level of works to bring it up to spec would have taken more time than actually just the planning phase.
Yes, so if you'd started planning earlier, you'd have had more time to put all those physical specs in. Is that true?
In a roundabout way, I could agree, but I think there's a difference between planning to make those changes and actually putting physical site works in place that would have allowed us to put ICU beds into that facility, rather than what it actually came about, the physical works that were able to step up the tower block and the Ulster Hospital.
But effectively, the Belfast City Hospital Tower was not the preferred option, all things being equal. You would have preferred it to be elsewhere.
All things being equal, the recommendation was that the Econ would have been a preferred site, but as it wasn't, as we weren't able to make it physically ready in the short time scale that we had, the Ulster, the tower block at the Ulster Hospital was the preferred site for actually being able to deliver that large-scale critical care that we would have needed.
Because I think, as this briefing paper sets out at paragraph 5, back on page 2, that the layout of the Belfast Hospital actually wasn't ideal, because the layout meant the maximum group of patients that can be safely managed is 24, but with the same staffing complement, the Nightingale in London is able to deliver care to 42.
That's correct.
So the location of the hospital, rather than being in a big site, was actually then limiting the ability for you to take in more patients. Now, as it turns out, the full capacity was never required.
Yeah. But can I maybe just to clarify and take a step back in regards to the Nightingale in London? If I recall, my lady, it wasn't critical care beds that was actually deployed in the Nightingale in London, whereas we were looking to critical care beds.
I think it may be that it was Wales or Scotland. I'm not sure it was London that wasn't critical. I thought that London
was the XL was critical.
Was it critical? Yeah. Sorry, apologies.
But you're certainly right that one of the nations, yes, it wasn't critical care.
Yeah.
Wales wasn't, but
Wales wasn't. Wales. Apologies, sorry. Yeah. No, and again, we were fitting something into the physical space that we had to be able to make the changes, the physical changes that we actually need. Whereas the Econ would have been the preferred site if we'd have had time to do that.
wasn't there another disadvantage about putting the Nightingale in the BCH tower, that you were putting the Nightingale in the middle of the regional cancer centre?
That's correct.
What were the consequences for infection prevention for those people who were suffering from cancer who were visiting BCH about having the Nightingale in the middle of the tower?
It was on specifically different floors, so there was that segregation between the provision of further or additional and continual services that were in the tower, as well as being able to adapt those floors that were used for the Nightingale.
Was there another difficulty caused by the BCH being in the Nightingale that it had a consequential impact on the ability to actually provide cancer care, because you didn't have the same level of facilities, you didn't have the same level of staff to be able to offer that cancer care because they were going to be required for the Nightingale?
It wasn't that those staff were being simply redeployed to the tower block. Again, we had to step down certain specialities, certain provisions that we wish we hadn't to have done so, my lady. But in regards to be able to complement the additionality in regards to critical care, and again referring back to the point in regards to the availability and the surplus of staff, was something that we did not have in Northern Ireland at that point.
I'm asking about a choice that did fall to you effectively about the location of the first Nightingale. If you hadn't put the Nightingale in the middle of the BCH tower, you could, had you chosen to do so, have continued to use those facilities to provide cancer care. Is that not right?
It wasn't that we had to stop cancer treatments in regards to the placement of and to supply the additional critical care beds. It was the fact that some of those treatments and supports were displaced elsewhere. In regards to what we did, but again, going back to the operational decision of the trusts in regards to do that, my lady, we had to step down services that we didn't wish we had to, in regards to what we had to do to support the COVID delivery of supporting patients. And again, I think it was something that, again, was more impacted in Northern Ireland due to the status and the state that the health service actually went into prior to COVID.
Let me ask one final question in relation to the first wave Nightingale. Do you remember how much it cost?
I don't.
I'm going to turn now to testing of patients and healthcare workers. At paragraph 301 of your statement, you say, "It was brought to my attention that there was not sufficient testing capacity, particularly at the start of the pandemic. To address this, in April 2020, I established an expert advisory group." Do you think, on reflection, that you sought to increase testing capacity early enough?
Testing in regards to where we finished up in the pandemic, in regards to the availability, the easy use tests that we had compared to where we were actually at the beginning, I think there was a rapid change in the science which was beneficial in regards to that. We had access to a number of not only in-house delivery mechanisms, but also public sector and private sector in Northern Ireland that we sought to make use of. In regards to where tests develop at a rapid pace, the testing facility in Northern Ireland, if we could have had more tests earlier, I think everybody would have been welcome of those.
But did you put a focus on ensuring that you ramped up all available sources of testing in Northern Ireland early enough?
There was a request across, because if I do recall, even my lady, we did make appeals and actually utilised some of the Department of Agriculture labs in regards to once testing platforms and testing specifics were actually identified as to what was necessary. And we were using AFPI facilities, we were using private care facilities and even private providers in regards to that.
Yes. I think the question is not what you did, but at the time that you started doing it. Do you think that you could have started securing that additional testing capacity at an earlier stage?
We could always have done something earlier if we'd have been able to facilitate and look at it in regards to where we were, in regards to what was needed to actually produce the tests and actually deliver the tests and actually produce the results reliably from them. I think we moved at pace in Northern Ireland in regards to how we were bringing together those different providers and different delivery avenues that we were able to bring together.
I want to move now away from the first wave and start to look at learning from the first wave ahead of the second. Staffing during the first wave. Were there any specific staffing shortages in terms of location, whether it be geographical, speciality, that were identified in the first wave?
In regards, I think it falls back to your earlier line of questioning in regards to the specifics around specific ICU care capacity in regards to what was necessary as we stepped up through those in regards to that. And I think that was the main one that I can recall, my lady.
So what steps do you take to improve staffing levels, particularly in critical care capacity?
Well, it was about that additional ability to bring in the different resources, also different ratios as well. But again, we were looking at a point where, as I said, new decade, new approach was actually about providing additional nursing training places. Nurses can't be trained in a matter of months nor weeks, and that's why we were looking to increase the nursing numbers, but also looking to see where those weaknesses were in regards to, I don't remember any specific additional training courses that were identified or delivered in preparation for the second wave.
Yes, but at this point in time, after the first wave, you've experienced the first wave, you've seen how health and social care has responded to it, you have an understanding of your capacity and your staffing. You had to work with the resources you had available to you. I think the department set out that it wasn't possible to train new nurses in that time. So what focus did you put on making sure that there was an increase in staffing as much as you possibly could to be able to respond in the event of a second wave?
We did put out a number of workforce appeals, but they were at the start more generic in regards to bringing in additional resource or looking towards bringing in those staff who had either just retired or were working elsewhere as to see if they can actually support health and social care. But my lady, moving from the first wave into the second wave, also had to be aware of the strain and the stress that was actually on an already overstretched workforce who had been on industrial action, come off industrial action, and then went headlong into a pandemic, facing something that healthcare workers we would never expected them to be facing at that pace and time. So there was a need as well to give them time to actually step back and recharge their batteries as well as we prepared for that second wave as well.
Did you do that?
Yes, we did as much as possible. I remember in regards to engaging with trusts and the chief nursing officer in regards to make sure that if there was leave available that could be taken, was taken. But again, that put additional strains on our ability to quickly re-step up other services as well, always cognizant of the critical nature of what we wanted to do against the resources that we actually had.
And was that with an eye on a potential for a second wave, or is that just to allow effectively staff to recover from the exertions of the first wave?
It was, in fact, it was a reflection of both, because I think moving into a second wave, in the first wave, we'd relied extensively on the goodwill and resilience of our healthcare staff, and without giving them time to have that time to, as I said, to recharge their batteries, actually to get their heads around what they had just been through prior to moving into a second wave. I think it was only fair and right to do that.
Because you mentioned earlier on about the workforce appeal. So was the workforce appeal the main route by which you were trying to bring in additional members into the workforce? There
was at that point, in regards to that workforce appeal, as to how we re-engaged additional resource into health and social care.
Because in your statement at paragraph 151, you say from April 2020 and throughout the second wave. Do you remember when the first workforce appeal went out?
I don't off the top of my head. Okay.
The workforce appeal handled almost 6,000 expressions of interest and generated over 35,000 formal applications. This level of interest delivered a total of 5,949 new temporary appointments, of which 2,800 were health and social care. The other appointments were non-medical covered support services. How was the workforce appeal meant to function in terms of how quickly were you meant to be getting workers in?
It was meant to be. It was actually subcontracted to a specialist in recruitment and in healthcare, as I recall, in regards to that we could turn around some of those appointments as quickly as possible. I was disappointed in regards to the high numbers of people who expressed an interest as to the numbers that actually were employed, but I think there was a number of legitimate reasons that we were given in regards to those people who were coming forward. Maybe not having the specific requirements, the specific training, or the ability to fix into slots where they were actually needed. I think one of my recommendations, if there is the further need for a workforce appeal, that they were actually targeted in regards to what we actually were needing, what we were requiring, and where we wanted to put that workforce in, because it worked when we went looking for social care workers, for GPs, and actually for our vaccination teams. When it was a targeted workforce appeal, we were able to get a more focused requirement. I think in regards to the general workforce appeal, people had applied looking for full-time positions rather than the temporary positions that the workforce appeal was offering. There was also people who I think were coming forward as an expression, what can I do, how can I help, rather than actually following through as to what the job may actually entail.
It's that targeted point that I want to pick up, because you also said earlier on that put a number of workforce, but they were at the start more generic, and you said there was a benefit when they were more targeted. Why wasn't the workforce appeal more targeted at the beginning?
Because I think the more targeted appeal was a learning from the first workforce appeal in regards to that, which it was just a generic, how can you come and help, what the workforce appeal was. And as I say, there was later examples that I actually just gave. When it was more targeted, it was more beneficial.
Was the reason why it was generic because it wasn't actually known exactly how these staff would be used?
Well, I think it was an ask for staff to come and help without, again, that targeted focus. And I think, your statements, not just it's not how they would be used, but it's also where they would be used and what they would be used for at that point. So it was more a generic ask than that focus ask, which the later appeals actually were.
And is that a consequence of the lack of planning to understand how many staff you would have available, where they needed to be, what specialities they need to be, so you then couldn't provide a targeted workforce appeal in order to plug those gaps?
Well, I think that's a fair assumption, yes, in regards to what that workforce appeal could have been rather than what it actually was.
And the logic of what you're saying in terms of if you think it'd be more targeted, it would be more successful.
Yes.
I think it would have been more successful.
I think it could have been more successful if we'd have knew at that point in time, again, my lady, as to how the generic workforce appeal. It was something, again, something our health and social care in Northern Ireland had never went out in that shape or form before. So it was something new. It was a novel approach for us, and we learned from it in regards to how a future one, if necessary, should be targeted and focused.
As far as you're aware, in the event of a future pandemic, is there a plan within the department for how you would conduct a future workforce appeal?
From my point, when I left the first time, I wasn't aware of any further work being done. That's not to say it hasn't been, but it's not something I can answer from my position at this time, nor when I came back in the second time was it brought to my attention that one had or was being developed.
Did you ask when you went back in the second time about what learning there'd been from between when you were first Health Minister and after the hiatus when you started again?
Unfortunately, when I went back in the second time, I was faced with the same difficulties as I did the first time, with staff once again being in industrial action. In regards to how to that, we'd been another 2 years without a Health Minister in post, and there were a number of specific decisions and requests that needed to be handled. And again, we were faced with an even worse situation in regards to our waiting list across all specialities and all disciplines in regards to that. So it wasn't something specifically that I asked in regards to had we updated our workforce appeal and how it could actually be utilised.
Could you not have asked for a briefing paper from the department to say, this is what we've learned?
I could have asked, and I think if I'd have been there longer, my lady, it had been something we could have got round to in regards to what was the normal working and day-to-day running of the Department of Health, rather than being back the first day after another 2-year hiatus without a minister in place.
You say if you'd been there longer, was it a matter of time to review this, or a matter of interest to review the learnings?
That definitely wasn't due to lack of interest, I can assure you. I went into that post the second time with my eyes wide open in regards to the difficulties that were in health and social care, and again in regards to one of the few parties who actually stepped up and took the health portfolio. I went back in to see what I could do, because I knew what pressures and strains the health service had been under the first time. I knew the difficulties come back in after not having a minister in place, but I willingly went into that post the second time.
Okay. Come back to planning for the second wave with the learnings from the first wave. In July 2020, the Critical Care Network asked trusts to provide an updated local surge plan. The second wave surge plan was produced in October 2020. Again, do you know why it took 3 months for that plan to be developed?
Well, I think in regards to taking the learnings from the first surge plan, making sure that it was robustly communicated, I don't know why it took 3 months, but I think a 3 month space from actually assessing the first one and developing the second one would be timely.
I mean, because by October 2020, you were aware that there was a possibility of a second wave if Northern Ireland wasn't already in the middle of a second wave.
Yeah.
So, did you ask, based on your experiences from the first wave, where's our plan? Where's our surge plan? How are we going to respond to escalating critical care?
In regard, there were continual surge plans and actually rebuild plans in regards to how we were trying to get the health service back on its feet as well. We already had the surge plans from the first wave as well to build on.
Yeah.
The specifics of the ask, I don't recall, my lady.
Is it you don't recall, or you don't recall whether you did ask?
I don't recall whether I did ask.
Can we just please display the two surge plans next to each other, which is the 16th of April surge plan, which is 377154, and then the October surge plan, which is 377221. I believe the one on the right is the one that you'd exhibited to your statement. Not a huge amount of difference between the two. If anything, the surge plan in October, the one on the right-hand side of our screen, is a scaled-down version of the initial surge plan. For example, we can see the extreme surge is equivalent to the high surge in the first plan. High surge is equivalent to medium surge, but the bed numbers are slightly less. Do you know why the surge plan for the second wave was a scaled-down version of the first wave?
I would assume at this point, in regards to actually the learnings from the first wave, in regards to the number of beds that were actually needed at each surge level, or actually at maximum capacity when we were using those critical care beds at the height of each wave.
So is this a reflection of the capacity of health and social care to scale up, or you're saying that this is actually all that was required by health and social care? This
is what was required. This is from the learnings of what was actually there, and it moves from local to regional escalation.
Okay. So were you satisfied then by October 2020 that there was this surge plan in place to be able to respond to the second wave?
Yes.
I want to ask then about the briefing that you gave to the executive on the 8th of October. You said all of our hospitals are currently under significant pressure. Most hospitals are running at more than 85% capacity, with some over 90%. There are already trolley waits in EDs and ambulances queuing outside. The level of pressure does not usually manifest until later in the year. There is therefore a concern about how the system will deal with rising pressures over the winter period, alongside increasing numbers of COVID-positive patients. That was the 8th of October. What did you actually do about those rising pressures in light of what you considered to be an impending second wave?
And that was where we actually moved to the surge planning in regards to what was there, in regards to how we actually began to step down other services. And again, as what had been actually unfortunately normal, my lady, during winter pressures in Northern Ireland when it came to those challenges as well.
Right, and in terms of the normal winter pressures, so your statement says, in the period since 21st of October, so this is a statement that you made, I believe, to the Assembly in December 2020, in which you said, in the period since 21st of October, regional bed capacity has not dropped below 92%. There are only 5 days on which it has been lower than 95%. Some hospital sites have consistently been operating above 100% capacity for that period. If I can just show that graphically at your statement, 492281, page 50. Thank you very much. This is the reflection in pictorial form of what you were telling the executive and the Assembly in October and then in December 2020. what steps had you taken between October 2020 and December 2020 in order to try and prevent these levels of occupation arising?
That was between those levels was actually the introduction of the non-pharmaceutical interventions that have been taken by the executive that we took through M2C in regards to the steps that we took as a society, as an executive, actually to break those chains of infection so we could cut down the number of beds that were actually COVID occupied. As can be seen from that graph, when the number of COVID beds actually increase, is when those additional beds and overcapacity actually put pressure on our system as well. So that's why we as a Department of Health we're asking for those additional interventions, especially in October and November and coming into the Christmas period that we've covered in M2C. Our aim was to reduce the number of COVID occupied beds in regards to how we actually implemented non-pharmaceutical interventions, but also increased the uptake of vaccination and other methods at that point in time, so we could break the reliance and the number of beds that were actually being utilised by COVID patients.
Yes, that's stopping people coming into hospital. But if in October hospitals are running at more than 85% capacity, and then that didn't drop below 92% from the 21st of October, what steps had you taken to try and make sure that there was going to be capacity for the second wave? I don't just mean critical care capacity, just generally, given the pressures that you were telling the executive.
Well, the decisions that we were taking, and it's actually in that statement in regards to how we reduce the pressures on our health and social care and on our hospitals and in bed capacity, was actually to reduce the number of COVID patients who were coming into hospital, and we did that through the non-pharmaceutical interventions because health was already at its peak, at the major stress of what it could actually deliver.
Okay. So we'll look at how you were looking to prioritise services and rebuild services a little bit later on. So I'll come back to this topic point then. Just want to ask one question about your statement. If we can just go to paragraph 144 of your statement, which is just on this same page. Thank you. I cannot recall the date on which regional critical care capacity fell below 90% for a period of 7 days in a row. When you were preparing this statement, did you check with the department whether they actually held that information or not?
Not that I can recall. If it's in my statement, that would what I would be considered to be factually correct.
Okay. If we can move then to the military assessment that was conducted of the surge plan, and if we can please go to its page INQ 0002763890002. So this is a briefing that was provided to you. If we just go back a page, we can see the cover sheet. Thank you. This is a briefing that provided to you on the 18th of December 2020, talking about the regional ICU surge plan. Now, we've looked at the levels of the surge plan. And if we can just go down to paragraph 3, please. It says, as you're aware, critical care surge plans were assessed by medical colleagues from 9th to the 11th of December 2020. Do you know why it had taken 2 months for there to be this assessment of the surge plan that had been published in October?
I'm not aware as to why it would have taken 2 months, but it may be because of the availability of the military assessment team and the response to a MACA request going in as well and actually been supplied to being able to conduct that assessment.
Well, there'd been a delay in planning for the first wave in terms of how long it had taken the surge plan to be produced. Did you take any steps to make sure that there was no delay in planning for the second wave?
In regards to the preparations that was already being made throughout the department, I think we were preparing for the second wave. In regards to this specific, as I say, I'll be bringing in the military assessment team. It would be dependent on their availability and the approval of the MACA request as well.
Right. So, following completion of their assessment, they made a number of recommendations. What was your reaction when you read the recommendations that had been provided by the military assessment team?
I was fully supportive that all the recommendations should be implemented as quickly as possible. I don't recall anything that was overtly challenging in regards to that. The sub that you've presented there as well. I also request. Well, I also say there was nothing actually for me to decide. It was all to note. So in regards, it was to the officials within the department informing me of what was happening.
Did you think those recommendations reflected structural issues within health and social care?
I think they highlighted, my lady, something that we probably knew and were aware of, and that's why we asked for that, I suppose, set of outside eyes to come in and actually reinforce and bring to focus what we needed to do.
Could you specify what it was that we probably knew and were aware of?
In regards to the recommendations, I think it was, going back to the earlier point about that need for that central control.
So did the department know that there was a lack of central control prior to this assessment and had done nothing about it?
No.
Or did they not think that there was much that needed to be done from central control?
There was a reliance that the CCA-NI was providing that level of central control, but that the military assessment actually highlighted that it needed to go a step farther.
Because if we can go down to page 9, because I'm going to look at some of these individual recommendations. So I think the way this briefing is structured is that you've got the briefing paper to you, there's then a summary of what the recommendations are and the department's response, and then behind that there are effectively the report or the summary of the military assessment team. And I just want to look first at recommendations 5 and 6. So recommendation 5 is very limited use made of a number of categories of staffing. That was something that could have been resolved at an earlier stage. Would you agree?
Yes. And that's why I say it was agreed by Health and Social Care Board and CCA-NI.
But it shouldn't have taken the military assessment team to tell you that you were underusing categories of people who could help provide extra capacity. Do you agree with that?
I would agree with that, but I think some of that additional capacity had been utilised elsewhere.
And then recommendation 6. Trusts appear to hold little flexibility or willingness to share redeployed staff to other trusts. Again, is that not a matter that if there had been that level of departmental control, rather than leaving it to the trusts, that would have been identified and potentially ironed out at a much earlier stage?
I also comes back to, and I see it was agreed by the Health and Social Care Board and CCA-NI to consider the issue of small deployable teams, and the department was asked to consider the issue of incentives. I think that goes back, my lady, unfortunately, to the employment structures that we have in Northern Ireland within health and social care, where staff are actually employed by the individual trust rather than an overall employment contract where they can be easily and readily deployed across a health and social care estate, which I think would be a benefit in future instances again.
Okay. My lady, I wonder if that might be a convenient point.
Yes, certainly. I shall return at 5 to you. Remember our breaks, Mr. Swann.
All rise.
Mr. Scott.
Thank you, Lady. Mr. Swann, if I can turn now to inequalities data, please. So, Aidan Dawson, gave evidence on behalf of the Public Health Agency, said when he was asked about surveillance of COVID-19 in the community by way of primary care data, that I don't think we had that sort of level of primary care data that we would require. This was in relation to his statement that said, for primary care, PHA had existing access to surveillance as a result of reporting of influenza-like illness attendances for in and out of hours primary care. The system was established during the 2009 influenza pandemic. This information was initially considered to be potentially relevant and useful, but upon discussion with HSCB, it was established that there were no permissions from the primary care data owners, so GPs, to use this source for COVID-19 monitoring, and it was not subsequently used. So, therefore appeals that there was a lack of surveillance of COVID-19 at primary care, and therefore surveillance of the community, due to data protection issues. Were you aware of that?
I wasn't aware of that, and actually when I heard Mr. Dawson's evidence, trying to recall what was actually there and what was actually done, because I do know that with my lady we had what was called sentinel GP practices that actually reported back in a number of influenza cases in regards to that, and then you know they were stepped up early on in the pandemic to actually report back in COVID cases. I'm not sure if what Mr. Dawson was actually talking about in regards to that data transfer, whether things were automatic or whether they actually had to be asked for an manual input actually as data being delivered through spreadsheets or written documentation, rather than having access to online systems or automatic data dumps, for want of a better explanation. I'm not sure where Mr. Dawson was going with that, but the surveillance of COVID-19 within primary care was something that we were alive to, because we actually took a step in Northern Ireland where we opened COVID centres, working with our primary care colleagues in Northern Ireland Committee and GPs and BMA in regards to where our primary care GPs actually set up specific COVID centres, working among our GP federations, so that if anybody was identifying with COVID symptoms, they were actually sent to those specific facilities rather than going into a GP practice as well. So I'm not sure in regards to exactly where Mr. Dawson was going to in that statement. It wasn't something that was raised with me as Minister in regards to those difficulties with that transfer of data between primary care and the PHA.
Well, I think he was talking about something a bit more fundamental than just transfer of data. I think what he's saying is that PHA didn't have access to the surveillance data that it was needing. And he said it took until August 2023 for that to be resolved. But is your evidence that actually you're never aware that there's any issues with any access to surveillance?
I wasn't aware of any issue in regards to that, because, my lady, we had other concerns that were actually raised in regards to that transfer of data, and we covered an M2C between ourselves and the Republic of Ireland that we worked on actually intensively. If something like that was actually in fact there and had been brought to my attention, we'd have worked on it as well.
Okay. But you wouldn't dispute the fact that Mr. Dawson had raised it as an issue, said it was an issue, and said it took a long time to be fixed?
Well, look, if he has raised it to the inquiry, I'm not disputing as to what Mr. Dawson has told the inquiry and his evidence. Conscious that he wasn't in the position he is now in regards to when we were during that as well. But if it's something he has raised, my lady, I'm sure there'll be further questions from the inquiry to the department.
Well, if it's not something you're aware of, then I'll move on to in terms of how deaths are actually counted. You set out in your statement that the health and social care response was mainly driven by community transmission, case numbers and HSC pressures, that the manner in which COVID-19 deaths were recorded did not have significant impact on the way that HSC responded to the pandemic. That's paragraph 86. Paragraph 87, you say that you agree to the CMO commissioning the PHA to provide relevant clinical data. You talk about the established system for monitoring and reporting deaths in Northern Ireland was through the General Register Office, and that system continued to operate throughout the pandemic and remained the definitive source of reporting on deaths in Northern Ireland. It appears from your statement that you're saying that actually there was sufficient surveillance of deaths through the General Register Office. So why was it necessary for PHA to be asked to provide data about deaths? And
I think that, my lady, was in regards to the frequency of reporting as well. NISRA were at that stage as the official collection and statistics agency reporting once a week. Elsewhere across the United Kingdom, there was a acknowledgement of the number of people who were losing their lives to COVID on a daily basis. I'd asked that Northern Ireland move to be in keeping with that. So PHA, through the CMO, had asked PHA to start to gather that data so that we can make sure that we were contributing the same data at the same level as other parts of the United Kingdom as well.
So did you consider that there was a data gap, or it was actually just trying to make sure there was comparison across?
I think it was making sure there was a comparable measure of number of cases, number of hospitalisations and number of deaths due to COVID, and that was the same measure and the same criteria across the United Kingdom, whereas NISRA were the official keepers of the GRO data.
So you're satisfied that if Northern Ireland had simply relied on the NISRA data, that you would have had all the information that you needed?
We would have, but it wouldn't have been coming at the frequency that was being asked for, was actually being sought from other parts of health and social care, but also what was actually being reported elsewhere actually on a daily basis.
Why did you not ask NISRA to increase the frequency rather than asking the PHA to design a new system?
I did. I wrote to NISRA. I asked them to increase that frequency. I think they moved to twice weekly reporting as well, because NISRA take, and again, my lady, this is from my understanding, NISRA take their official statistics from returned death certificates, so there always was the delay in regards to those coming back into them as a central reporting agency, and that was my understanding at the time.
Okay. Move on to monitoring deaths of healthcare workers. So a letter sent from the CMO to trusts on the 12th of May 2020 conveyed your request for all trusts to advise the department on a daily basis of the number of health and social care workers who died with or from COVID. And for reference, that's INQ 00490088. Why did you want that data?
It was also something that was being asked for at a UK-wide basis level as well. I wanted to ensure that we were getting the appropriate data in regards to our healthcare workers, my healthcare workers, my lady also, not just in regards to the number of healthcare workers who were losing their lives due to COVID, but also I asked for the further as to how many were being hospitalised, how many were in ICU, in regards to the effect that COVID was actually having on our workforce.
Was the driver for that you, or seeking to have an equivalence to the UK-wide basis?
It started off, there was a request at a UK-wide basis. I actually at that point felt that our system hadn't responded, and that's why I asked for it to be done.
What did you do with that information?
I was aware of it. Now, I think something that has been brought to my attention through earlier evidence statements was that the department wasn't collating that centrally. Mm-hmm. It was being reported through Silver and Gold command reports, but I don't think there was actually a central correlation as to that data.
So when you asked for that information, did you think that there had been a bit of gap in the mechanism by which that information had been gathered?
It wasn't something that had previously been gathered before through any of the other pandemics, so I think it was a different request that it actually came.
Okay. And in terms of the request, didn't you also want to know the role that the healthcare worker was working in at the time?
Yes, I wanted to know where. Yeah.
Did you get that information?
Not that, I think that was been reported through Silver to Gold in regards to where they were and who they were, actually in that regards. And I think looking through previous evidence bundles, I think Chris Hagan from the Belfast Trust had actually provided that in his evidence proposals.
It looks like a slightly disjointed picture. Weren't you looking for the information that you wanted to get it as a whole in one easy to access piece of information? Yes,
that's what I'd requested, but as I say, I don't recall that ever being formally tabulated through the department.
Well, if that's what you'd requested, why isn't that what you got?
Well, I suppose I was getting that data through Silver and Gold reports as well, rather than just a regular update coming from the department to myself.
Did you not also want to know what the ethnicity was of the healthcare workers?
Not at that point in time. It wasn't a question that we were asking, unfortunately. It's not something that was generally recorded, actually, in Northern Ireland systems, my lady. I know it's something that you have taken an interest in and has been raised in previous evidence sessions as well.
Well, you say not at that point in time. So the letter conveying your request is dated the 12th of May. Chief Medical Officer, when he gave evidence, it's page 22 of his transcript, says it was in April 2020 that he became aware of those from an ethnic minority background may suffer disproportionate impact. So by the time that you made the request, it was known that there was a disproportionate impact upon ethnic minorities. So why did you say not at that point in time?
Well, sorry, in response to the answer, I don't think there was the linkage of the request of data between ethnic identification of our healthcare workers and those who were losing their lives and those who were hospitalised.
Was it not a link that you were making in your head about if this seems to be a disproportionate impact upon healthcare workers, that you wanted to know what the impact was on healthcare workers, your healthcare workers who used the phrase earlier on?
It wasn't a linkage that I made at that point in time, because I think I was caring about my healthcare workers, irrespective of ethnicity.
But you're talking about those who may be potentially the most at risk.
As were all our healthcare workers, and I think that's the lack of our data, and I think of the data systems that we have in Northern Ireland that doesn't actually record that level of detail of individuals.
Well, let's look at this in a different way. So every March, there's a health and social care workforce census. Is that correct?
That's correct, yeah.
And that census doesn't record the ethnicity of healthcare workers, does it?
Not that I'm aware of.
Why is that?
I don't know. But I think one of the learnings coming out of this inquiry, my lady, is that it should, in regards to that, because I know there has been a general weakness in Northern Ireland in regards to the recording of ethnicity of workforce across Northern Ireland, not just in health and social care, but also in Northern Ireland civil service as well.
Wasn't it important information? Because if you don't know how many of your healthcare workers are minority ethnic, how can you work out questions such as how to risk assess them, how many staff you might lose to illness, any additional measures that might be required?
I would agree, my lady. It's an apparent weakness in regards to that data collection in Northern Ireland that needs to be addressed.
Yeah. Who's responsible for collecting that data?
I'm not sure who actually carries that.
Okay. Who do you think should be?
Well, the department should within its workforce directorate.
Okay. Well, if the department should be, then why isn't it?
Look, I think, as the previous health minister, as I said here, I think it should, and I think going forward there would be a recommendation that could be made in regards to that. Why it's not been done, I can't answer that.
But as the health minister, aren't you responsible essentially for making sure that there is sufficient understanding of your workforce?
Yes, and it goes back to the understanding of knowing what to ask and when to ask it. And I think one of the weaknesses that has been brought to fore in regards to the outworkings of this inquiry is that fact, my lady.
Or even in non-pandemic times, wouldn't you want to know the ethnicity of your workforce?
It hasn't been something that was previously asked for in regards to those annual workforce returns, but in regards to what, as I've said, what has been brought to fore in regards to this evidence session and previous evidence sessions, I think it is something that should be done.
Well, just one final question in that. Health and social care is under a duty under the Northern Ireland Act to promote equality, correct?
Correct.
How could it do that if it doesn't know the ethnicity of its workforce?
In regards to, I suppose, Section 75 requirements in Northern Ireland, there's a number of different strands across the workforce and across the department that are undertaken, and it goes back to the weakness in data collection, and it's not something that I can say that I'm proud of, that we weren't doing it, but it's something, my lady, that I acknowledge this is something that we should be doing.
Professor Brammer, on behalf of FEMHO, gave evidence to Module 3, says it's about retention and recruitment as well, isn't it? If everybody feels valued, then they'll give the best in their job. And if they're just a statistic or even a non-statistic, then how are they going to do their best for the NHS? So isn't it also, in a sense, self-sabotaging for the department not to know about the ethnicity of its workforce? It
is, yes, but it's also, I think my lady goes further in regards to that, in regards to the professor's statement, in regards to how you treat your workforce. And again, I don't think Northern Ireland has been good at treating its health service workforce at all, or we wouldn't be now looking, even with the restoration of an executive, of the potential again of industrial action in Northern Ireland. So that's a collective responsibility that the Executive and the Assembly needs to address and should be addressing in regards to that.
Yes, but those are completely two unrelated points about those issues in terms of the restoration of the executive and industrial action and whether the health and social care knows the ethnicity of its workforce.
But I think it goes back to the point being made and the question being asked in regards to how do you respect, value and retain staff within the health and social care, and not just in Northern Ireland but actually across the piece in regards to you give everybody that equal respect and give them the value that they deserve. If the point is we haven't been collecting that data, I've admitted to it that I think we should in regards to that, and I think it's a weakness that the inquiry has brought to the fore that I think needs to be addressed.
And presumably all the points you're making about ethnicity are not just about healthcare workers, it also applies to understanding the ethnicity of your patients, is that correct?
That's correct, yes.
Is there also sufficient collection of disability data about the population of Northern Ireland and how it interacts with health and social care?
I don't think there is in regards to the generic definition of disability, and I hope that is actually corrected and addressed with the introduction of Encompass in regards to what data is actually held centrally in one system. My lady, when we were looking at the introduction of or the issue of letters to those who were clinically extremely vulnerable, I know at the start of the pandemic it took significant trawling of various databases actually to identify who was to get a letter and who should have got a letter, whereas I hope that the introduction, and from what I've been told, the introduction of Encompass should make that a more efficient and easier system to use because of that data actually being held centrally.
Okay. I'm going to move on and look at visiting restrictions. Do you consider that visiting restrictions throughout the course of the pandemic struck the right balance between the benefits of visits to patients and their families and reducing the risk of visits bringing in infection?
I do, but I also acknowledge and respect that they were difficult. They were difficult for people who had people in hospitals, and that included at one point my own family as well, in regards to members of my family who were in hospital during the pandemic as well. But those balances that were brought and those guidelines that were actually introduced were done so, I think, in the balance of protections in regards to what was known about the pandemic and the virus at any individual time. And I think that's why the CNO was always keen to provide those refreshments and those updates as and when we were able to do that.
Yes. You say in your statement that you were advised of any changes to the level of applicable restrictions and my endorsement sought at every stage. That's the advice that you're being provided by the CNO.
That's correct.
Was that an area where you felt competent to challenge the advice, if you sought to challenge it, of the CNO?
It was on occasion. I do believe there was a couple of occasions that I did challenge. The specifics I don't recall at this moment in time, but there actually was a number of occasions where maybe not challenged but questioned in regards to the advice that was being given.
Okay, so, but you don't remember those specifics?
I don't remember, not at this
time. There's one in your statement you refer to, it's a paragraph 241. On 16th of April 2020, I asked Critical Care Network to undertake a rapid review of the situation with respect to visiting within Northern Ireland intensive care units at the end of life, as I was keen to facilitate visiting in such circumstances. Could you provide a little bit more detail, if you remember it, about the reason why you asked that on the 16th of April?
I do, my lady, in regards to that, because the initial visiting guidance was that there should be end-of-life visiting should be permitted, but I think the initial guidance actually said with the exception of ICU, so it wasn't advised. The guidelines were against end-of-life visiting with an ICU, and I felt that there should be opportunity for people to visit with a loved one at the end of life, even if they were in ICU. So I did ask the CNO to have a look at that again to see if it was possible, and if my recollection was there were provisions then made to enable that.
There was a discussion on the 17th of April at the Executive Committee meeting about the balance of visiting and whether it was struck correctly. Why did you take that topic to the executive?
Because those updates at the executive were generic, well, not generic, they were all-encompassing conversations that were being had around the executive table. All executive ministers at that point were interested in what was happening. I thought it was important that all my executive colleagues were updated in regards to what was actually happening, especially in regards to visiting. I'm not sure if it's something that an individual minister had raised with me in regards to that specific point.
Because it could be seen that because a minister takes a matter to the executive that it's seen as a political issue. Did you consider visiting as a political issue or more of a clinical issue?
No, it was more of a clinical and humane issue in regards to what we needed to do, and I think, I hope, my lady, during my tenure as health minister, especially during the pandemic, that politics didn't enter into any of the decisions that I made.
The inquiries received a report about Every Story Matters in terms of a lot of extensive work that's been done to gather accounts from all across the United Kingdom. Some of those are included in your evidence proposal. Do you recognise the stories about the pain that was caused by the lack of people to visit their loved ones in hospital?
I do, my lady. Having watched the video in regards to, and again in regards to the opening of this model just last night in preparation of today, those stories are heartfelt. They're reflective of the experiences of many people across Northern Ireland, our health and social care workers, the departmental workers, and even in regards, as I said, my lady, in regards to even my own family in times.
When John's campaign gave evidence, their view was that there should be a find a way to say yes approach to visiting. Do you think that was an approach that was adopted in Northern Ireland?
I do, and I think not just in regards to the doctors, but I think in regards to the nurses on the wards as well, in regards to that ability to look for those individual matters as well. But I also think it was reflective, my lady, and again I'll go back to that engagement, I think it was reflective of the work that the Chief Nursing Officer led, because of her understanding and compassionate role that she brought as a profession actually to the guidance that she was developing. So it wasn't just a specific policy guideline being created by a civil service. She actually brought that empathy and understanding, I think, as a professional nurse as well. And I believe that was reflected in our guidance.
I mean, Module 2C heard a lot of evidence about the importance and focus that Northern Ireland puts on death and the circumstances of death. Is that something that played into the consideration of the balance to be drawn, particularly for end-of-life visiting?
It was. And again, I think there is that value of end-of-life and of death in Northern Ireland, my lady. I know it's something that was particularly challenging in regards to guidance and guidelines, specifically around funerals in Northern Ireland and wakes.
I don't want to take it outside, just in terms of the visiting restrictions.
But I know in regards to that overall, not just the end of life, because I think that how Northern Ireland looks to death and the celebration of life is more ingrained in Northern Ireland society. So it's not just that end of life visiting within hospital. There was a wider package around that. But I think, going back to that change that was asked about the end of life in ICU, that was something that we asked for. Unfortunately, my lady, it wasn't always something that was possible on every occasion, and I think the Every Story Matters videos and evidence that has been presented by different individuals across the United Kingdom and Northern Ireland specifically reflects that level of challenge and empathy. It's not a situation, my lady, that I'd want to put any family in or any individual in, but in regards to where we were at certain points in time, what we knew, what guidance was there, unfortunately it was necessary at times.
I want to ask you about care partners, and specifically about care partners in hospital, so nothing to do with the care sector. So it's right that care partners were introduced on the 23rd of September 2020 in relation to visiting care homes, correct?
That's correct, yeah.
Were they introduced at the same time for visiting at a hospital or not?
They were introduced at a later stage.
Why were they not introduced in hospital visiting at the same time?
I'm unaware as to the specifics, but in regards, they were brought in to meet the specific needs within care homes and social care setting as well, in regards to how they could be supported for those people who were in care homes and social care settings were actually there for a longer term and a longer duration. I'm unsure as to why it took that additional period of time before they were actually introduced into hospital settings. But I'm aware that the care partner relationship was actually something that was promoted again by the CNO in regards to how we supported visiting within care homes.
You're speeding up.
Apologies, sorry.
So the Department of Health statement defines care partners, specific individuals allow the introduction of individualised and tailored arrangements to assist in meeting the needs of the patient. Based on what you were saying, that wasn't the same specific need arising in hospitals as it was in care homes. Is that correct?
There was, I don't want to misrepresent what I was saying in regards to that, but there was those specific needs within hospitals, but the care partner arrangement wasn't introduced in hospitals till a later date.
On reflection, do you think that the care partner scheme should have been introduced in hospitals earlier?
In reflection, and again, my lady, it goes back to what I know now compared to what I know then, what I knew then. In regards to the introduction of care partners, on reflection, I wish we'd have brought it in earlier in the care home and domiciliary care settings in regards to what we're doing. And in reflection, take that to the next step is, yes, I do think we could have brought it in earlier within hospital settings as well. But again, that's knowing what we know now to where we were then.
Okay. Because one of the main problems that was caused by visiting restrictions was that people didn't have the same level of ability to communicate with their family members who are in hospital. You remember people expressing their views that they weren't able to actually understand what was happening to their loved ones.
That's, yeah.
Do you think there was enough done within health and social care to help families have a current, up-to-date understanding of how their loved one was getting on in hospital?
I do, but I'm also aware of the weaknesses where the communication systems that we hoped and envisaged to be in place across different hospitals, different trusts, let patients down, let families down at specific points. But I know also that the dedication and delivery of our health care workers who were with individuals at that very challenging point within their time as well was also a challenge to them, something that they weren't expected to do when they first took up their posts as well. In regards to that, just the additional asks and strains that we were putting on our staff as well. But you know, could we have done more? Could we do more? Yes, knowing what we know now in regards to additional PPEs, testing, all the rest of it, as to how we could actually facilitate that. And I think as visiting guidance and guidelines progressed, I think that was something that was taken into account.
You say the communication systems that we hoped and envisaged being in place let patients down, let families down. How did those failures occur?
Well, I think it was always at that point in time on the workload in regards to the staff that were actually working on wards and being able to provide that up-to-date information and data in regards to how a loved one was being. Actually, the update of their care on a ward wasn't always possible in the time they need, and I do know that in the occasions where that does cause stress, I'll apologise, you know, that we weren't able to get it right every time, but there were many wards, many healthcare workers who were providing that care, that information, where we were able to meet those needs, and the needs where we failed. I want to apologise, my lady, because it's not something that we would, something that the healthcare service or even those working on those wards would have wanted to happen.
Could more use have been made of non-clinical staff to be able to do that uploading onto the systems, or to provide an extra resource to do those tasks to help provide that communication? There
could have been opportunities to do that as well, but always taking into consideration of the infection control and the ability of healthcare staff to do that. I know it is something that I think some trusts and some wards did actually do, but I'm not aware that it was something that was actually promoted across all hospital sites.
Has there been a review done of the department about how that system could be improved in future?
I'm not sure at this point, having left office in regards to that, and again, it's not something that I'd asked for an update on.
I'm going to move on to PPE and RPE. It's correct that you didn't have any involvement in creating or overseeing the guidance about what PPE should be used in different circumstances in healthcare settings?
That's correct.
Did you have any understanding, and maybe the answer is no based on what you previously said, did you have any understanding about whether FFP3 masks were more protective than FRSM, so the blue fluid resistant masks?
No.
So you didn't have any understanding, or you didn't think there was any difference?
I didn't have any understanding.
I just want to ask you about a meeting that you had on the 24th of March 2020 with the First Minister and the Deputy First Minister and a number of officials. If we can have on screen INQ 000 289 853. Thank you very much. So you can see there, so it's from the health side of things, there's yourself, CMO, CNO, Chief Pharmaceutical Officer, and then the senior official from the Department of Health, correct?
That's correct, yeah.
And then just under PPE, we have DOH noted that there's a misperception that PPE is a major problem. Was PPE access from healthcare workers within hospitals a problem within Northern Ireland over the pandemic?
It was a problem at the start, but as the note goes on to describe, and as we worked out, our PPE supply mechanisms across health and social care wasn't as robust as it could have been, and it wasn't in a position where, it was reliant on PPE being something that was always there, always available, and just in time development and deployment. And I think that's something that was reflective across health and social care, not just in Northern Ireland, but the UK and even worldwide in regards to that.
Because I'm acutely conscious that there's another module coming up that will deal with procurement. So are you saying that these issues in terms of access were more procurement issues for BSO?
Well, it was a mixture of both from procurement and delivery and management of PPE across all our sites, where it was always that, and my understanding at the start was individual wards were able to order what PPE they needed and always had that supply, whereas through the pandemic in the early stages it was something that was more of a controlled management system at trust level and BSO level.
So that kind of trust level, how quickly was that situation resolved in terms of delivery and storage?
It was quickly resourced in regards to BSO and PALs working in conjunction.
Okay. So by the date of this meeting, the 24th of March 2020, the kind of local level, the trust level issues with access to PPE had been resolved?
Well, I wouldn't say they've been resolved, but it had been noticed there's some issues with management of PPE by trusts and healthcare professionals. Need to avoid the use of it when it's not needed in regards to that. So there was those challenges as well. And again, going down through the document, more videos and development about who used them, where it was, and again about how we went about actually introducing measures to calm fears in regards to the clear need and messaging around PPE that it should be used. At that point in time, we were also looking, as the final bullet actually points to, is the release of the pandemic stock, which has been held at a UK level.
So it's the calming fears, it's the point above that I actually wanted to ask you about. It says DOH have introduced additional measures to calm fears. Did you hear concerns from healthcare workers that they didn't feel safe with the PPE that they'd been given?
Yes, and again, that was, I think, work that again, and my lady, I'm conscious about continually referring to the CNO, but it's come back to I think, her evidence as well in regards to, I think, the very detailed work that she did, along with her colleagues in regards to the explanation videos in regards to what PPE was used in specific issues and specific situations as well. And I know she put a lot of work and dedication in actually developing videos that were distributed throughout the system as well as to what to wear, when to wear it and how to wear it.
So did those concerns about healthcare workers not feeling safe, did they disappear throughout the course of the pandemic?
No, there was always that general concern. I think one of the steps that we actually took was the creation of a specific email address.
PPE inbox?
PPE inbox, yes, where it was advertised and widely spread across that if anybody had those specific concerns, they could email that inbox directly and their query, their concern would be dealt with anonymously.
Yes. And you set out the details, or the department set out the details of that inbox in the statement, so I'm not going to ask you about that. But from your perspective, hearing those concerns of healthcare workers, did you feel that the CNO was doing enough to address those concerns?
Yes. As I say, my lady, I'm conscious that I'm speaking here in her absence on her behalf, but I think the level of dedication that the CNO put into addressing those specific issues, I think were to be commended.
I want to ask you about, in your statement, which paragraph 289, it appears to relate to fit testing, but I wonder if you can expand upon this. You say, I regret, however, I cannot recall being made of issues specifically in relation to age, race, disability or pregnancy, and so I did not take any steps to address them. Could you expand upon what you mean by that paragraph?
And I think in regards to the flow of the statement, I think it was, as I think if you've indicated, it was around fit testing, and I don't think there was any of those specific issues were brought to my attention as to why we were seeing at that point was actually the number of failures in regards to staff coming forward for the fit testing.
So you recognise that there were failures?
There were, yes, there was quite an extensive piece of work in regards around that, because we did see, I think it was one of the contractors who were actually brought in by the trusts to conduct the fit testing, that there were a high number of staff had actually failed those or passed those when they shouldn't, and the contractor was then challenged in regards to that.
Do you think that those failures, and particularly in relation to age, race, disability or pregnancy, should have been brought to your attention?
If that was one of the reasons why those tests were being failed, yes.
Just moving to the PPE review. So on the 15th of April 2020, you commissioned a rapid review that was led by the department's internal audit team of PPE to assess the appropriate receipt, storage, distribution. Was that in response to concerns raised by healthcare workers in the first wave, or was that planning for the second wave?
I think it was a mixture of both. It was an issue that had been raised. PPE was an issue I think was live across all parts of health and social care, not just in regards to the supply, the distribution and the utilisation. My lady, again, I think in Northern Ireland we kept that within BSO, within PALS, and were able to make sure that supply and purchasing system was I believe, quite robust.
The terms of reference for that review didn't include any equalities issues. Do you know why not?
In regards at that point, I think it was specifically to look at the supply and distribution and purchasing of PPE.
As far as you're aware, had there been issues raised about inequalities within PPE in terms of difficulties fit testing?
At that point, I was aware there were some issues, and again, brought to me in regards to masks not maybe being specifically accessible or utilisation with women's smaller faces in regards to that, so there was work done in regards to that.
Should that not have been included in the review? If you're reviewing PPE as a whole, should you not want to include equalities issues?
It could, in reflection, it could have been. It wasn't at that stage. My lady, I'm unsure why it wasn't included at that point.
It seems that there's a number of instances where there's a failure of the department to consider what seem to be fairly fundamental questions of equalities. Does the department actually hold equalities at the centre of all the decisions that it takes?
Again, my lady, from responding now in my position and not being able to speak on behalf of the department, I would hope that it did. But coming out from even this morning's evidence session and from previous evidence sessions, there may be a query that it needs actually to do more.
Say a query that needs to do more, or would you go further than that?
I would go, speaking in a personal capacity, my lady, I think it should go further. I said that in an earlier session in regards to previous answers as well.
Going to move now to the support that was provided to healthcare workers. You talked earlier on about after the first wave there was a need for effectively rest and recuperation for healthcare workers. Do you think throughout the course of the pandemic, whether first wave, second wave or subsequently, that there was sufficient support given to healthcare workers?
I think at the beginning there wasn't, but I think as we moved through the pandemic, the additional supports again identified through the Chief Nursing Officer and our Chief Professionals, Chief Medical Officer, was additional number of pieces of work actually brought into how we engaged and how we supported our workers as well. I'm aware that the Chief Nursing Officer actually worked with our regional trauma network, my lady, in regards to the pressures that were on our health and social care staff. Regional Trauma Network being a specific body in Northern Ireland that looks to help and support victims and survivors of the Troubles in regards to the psychological pressures that they're under. So I do know that she reached into them as to what supports could be given to our healthcare workers. There was a development of, I think, the Thrive project as well, and I'm aware that the Chief Scientific Advisor actually commissioned work through the Ulster University in regards to the pressures that had came on on our healthcare workers in response to that. And I think Thrive actually engendered that, or engaged psychological supports.
Psychological support's the area that I'm particularly of interest, because your statements talked about a number of areas of psychological support that's been provided. Was there actually 24-hour psychological support available to healthcare workers?
I'm not aware. I don't have the detail of that specific contract and that support that was actually delivered.
Well, I think we've seen documentation which shows it was 9 to 5, Monday to Friday. Do you think that there should have been 24-hour?
In reflection, yes, in regards to what should have been available, what could have been available, I would have made a better use.
You say in reflection, is that not a reflection that should have been made ahead of at least the second wave?
Yes.
Just want to ask two other points about additional support. So the Department of Health Emergency Response Strategy from March 2020 talks about providing free travel for health and social care workers on public transport and making car parking free for staff. And car parking and free public transport was provided from April to June 2020, and then it wasn't provided after that. Is that correct?
I think it was provided at later dates as well in regards to the ability to do that. I know it was actually a result of a private member's bill in regards to the Assembly as to making car parking free at all hospital sites, both for staff and visitors alike. We also provided not just free car parking and that free travel, that was working with the Department of Infrastructure, supports to childcare. We provided a £500 payment to all health and social care staff without tax or national insurance being taken from it as well in regards to that. The reason I'm asking this question is that the military assessment team from December 2020 that we looked at earlier on say that simple incentives, beverages, food, free parking, laundry, etc., should not be underestimated and should be equitable and transparent across all trusts. That was the assessment in December 2020. Does that not indicate that those basic necessities hadn't been provided for all healthcare workers prior to that date? They have been provided, but not just on. I think what the military assessment is actually saying is that we shouldn't underestimate the value of those things, rather than the fact that we haven't been providing them, if I'm correct, because we have been providing childcare support, as I say, and the free car parking as well. And again, one of the steps that I took, my lady, was actually £15 million across our 5 geographical trusts, putting £3 million into each trust charitable status, so they could actually utilise that into how they would support their staff over and above what was, I suppose, general costs that were available to them.
I'm going to move on to DNA CPRs and advanced care planning. At any stage of the pandemic, were you made aware of concerns that blanket or inappropriate DNA CPRs were being imposed upon patients?
Not that they were being imposed upon patients, but I am aware that there were a number of written questions from Assembly members and correspondence, and my replies to those is one that I believe that they were unethical and not necessary to be actually deployed based on age or disability.
Yes, I just want to tease that out because I think you set this out in your statement, paragraph 307, where you say, I received a number of written questions from my fellow M&As asking about the application of DNA CPRs. In my response, I made it clear that orders based on age or disability were discriminatory and unethical. In terms of the policy in Northern Ireland, media reports were ill-founded. It's that last sentence that I just want to focus on. In response to those MLAs, were you saying that complaints of any inappropriate use were ill-founded, or that it was ill-founded to suggest that there was a blanket DNA CPR as a policy in Northern Ireland?
It was ill-founded that there was a blanket response.
On what basis were you saying that it was ill-founded, there was a blanket response? How did you know that? On
feedback from officials in regards to that, my lady, in regards to if that was a response that I'd have had to either an MLA question or members' correspondence, not just in response, but there would have been backup documentation supplied with that statement as well.
So you're satisfied that there was a response provided to the department from presumably the trusts,
yeah,
that have provided documentation setting out an assessment of whether the DNA CPRs have been applied inappropriately?
That they were being applied appropriately and there wasn't a blanket response.
You're aware of the concerns of families that there was an increased number of DNA CPRs being applied to patients being admitted to hospital. Is that right?
I was aware there was concerns being raised, yes.
And what did you do in response to the concerns about an increase in numbers rather than inappropriate usage?
Well, again, those DNA CPRs were medical assessments in regards, and they should have been, on all occasions, from my understanding, and negotiated or discussed in regards to the individual and the family as well.
Because this was an area, would you agree, that requires maximum transparency in order to dispel family concerns about the use of DNA CPRs?
Yes.
So there was a review done by CQC in England. Why wasn't there an equivalent in Northern Ireland?
I believe the CQC investigation actually covered Northern Ireland as well in regards to some of their responses.
But there wasn't an in-depth assessment done of DNA CPRs that had been imposed in Northern Ireland?
No.
Do you think that there should have been in order to provide that level of transparency that might have assisted families?
Well, I think taken from what I'm aware of, there was a reliance on the work that had been done by CQC.
It's true that the DNA CPR forms weren't available on the Northern Ireland electronic care record, is that right?
I'm not aware of that, my lady.
Okay. That is from the statement of the witness on behalf of the Western Trust, who gave evidence to the Spotlight Hospital. As far as you're aware, did an ability to actually collate DNA CPR forms play any role in not ordering a review that could then be published?
It's not that I'm aware of.
You were involved in what's called in your statement a single integrated process for advanced care planning to support DNA CPRs that was approved for publication in October 2020. Is that the respect forms that you're talking about?
And the care planning looks at, I suppose, planning for all aspects, should it be financial, inheritance, and engaging with families in early occasion.
Yes, because it's right, isn't it, that actually there's no power in Northern Ireland to provide a lasting power of attorney that covers health and social care decisions.
That's correct.
Because those powers do exist under the Mental Capacity Act Northern Ireland 2016, but they've never actually been brought into force.
That's correct.
Do you think that during a pandemic it's beneficial for there to be an option for people to put in place a lasting power of attorney?
There should be the option in regards to that, and I think coming out of this inquiry and again today's session, I think it would be a recommendation that I would bring forward, or even ask my executive colleagues to look at in regards to the legislative basis for that, because I do believe, my lady, that across, although it is a Department of Health, there is a Department of Justice requirement for input too.
Why wasn't that something that was looked at in the middle of 2020, for example, about bringing those provisions into...
I'm not aware why it wasn't raised at that point. It's definitely something that wasn't brought to my attention, nor was it something that I contemplated.
It's difficult to ask why you didn't contemplate something, but I'll try anyway. Is that not something that you should have thought about using the powers that are available to the Department for Health to actually plug a gap that would have been beneficial for the pandemic?
It actually wasn't until preparing for this evidence session that I was made aware that that lasting power of attorney wasn't available in Northern Ireland under those occasions.
So you didn't know that until 2024?
That's correct.
My lady, I'll be moving on to another topic. Is that a convenient moment to break
If
for
we're
lunch?
moving to another topic, certainly. Very well, we shall return at 2:45, and I promise we will finish your evidence today, Mr. Swann.
Thank you, my lady.
All rise.